Welcome to this episode of the Glaucoma and Retina Clinical Podcast Series, brought to you by the American Academy of Optometry Foundation. Today's episode will discuss determinants of 4-year visual acuity loss in geographic atrophy. My name is Pathik, Amin, and I'll be your host. I'm an associate professor at the Illinois Eye and Ear Infirmary at the University of Illinois at Chicago, and I'm excited to be joined by Dr. Brian Bucca, who's an associate professor at the University of Colorado, where he's the director of the eye clinic at the Barbara Davis Eye Center, as well as the director for the Fundus Photography and Retinopathy Reading Center. Thanks for joining us today, Dr. Bucca.
My pleasure. Thanks for having me.
So our article today is titled Determinants of 4-Year Visual Acuity Loss in Geographic Atrophy. This was published just this month, July of 2025, by Shen and colleagues in the journal titled Ophthalmology. So why did you choose this article, Dr. Bucca?
Well, the article's important. Wet ARMD has gotten all the love, and it's time for dry ARMD to have its time in the spotlight, I think. We've been waiting for these treatments for a long time, and it is the most common form of ARMD, and it is responsible for vision loss to large degrees. So understanding these medications and who to use them in is important.
Yeah, no, it's certainly an exciting time. I remember just in residency at the VA, we'd see a lot of vets with, GA, and you felt kind of helpless because there was really no sort of treatment. And so these new therapies are exciting. And so, I think the discussion has been around anytime there's a new sort of therapy out is, well, which patients might benefit most, right? These drugs are typically injected monthly or bi-monthly, and you have an enormous burden on patients, but as well as their caregivers, the healthcare system in general. Does this study help provide clarity on who should be treated, who would benefit most from these new therapies?
Yeah, I think it does. And this may just be a starting point, but at least we have some guidance to tell us who benefits more from a visual standpoint. Some of the past studies that have looked at the effectiveness of these medications have reported that geographic atrophy spread is less, but who benefits more in terms of visual acuity? So this study tells us through statistical analysis that somehow 2160 is the cutoff for who these medications, I say that tongue in cheek, but 2160 became the marker for who would benefit most or not. So people who had better than 2160 vision lost less acuity over a 4-year period versus those who saw worse than 2160. So you can kind of think of that as if you have more vision to lose, then you stand to lose that vision, right? The other important marker was the proximity of the geographic lesions to the fovea. And we're talking close here, 1 millimeter and shorter to the foveal center this makes a lot of sense, was statistically related to acuity loss over a 4-year period as well. And also what was found is that the rate of the growth towards the center of the fovea also makes a lot of sense, was also associated with vision loss over a 4-year period.
Yeah, no, very interesting. And the data is compelling in terms of identifying these patients with, as you said, more vision to lose. In reviewing the paper, the data that the study authors looked at were AREDS and AREDS 2 participants, and these were folks enrolled in the 90s and 2000s, respectively. And they relied on color fundus photos to look at, location and spread of GA. Since that time, OCT has really become the mainstay of retinal disease imaging. Certainly a lot of the retina specialists that I work with here are really just getting serial OCTs and not really always fundus photos. Does this affect how we should view the results of the study? Potentially there's maybe less accuracy or sensitivity with photos, but what are your thoughts on this?
Well, thinking about OCT, you're kind of looking for those transmission defects, that are consistent with geographic lesions. I don't know if we can really apply that right now. The study gives us what it gives us, and that's the technology we had when the ARED study was being conducted. So right now, I think we should stick to fundus photographs. Those studies were conducted well. They gathered all the data that they thought was available to them, but all of the covariates, and it was an excellent database to go back and try to answer these questions. And that's what you get with good, large longitudinal studies that last for a long time. You can go back and mine those studies. So maybe moving forward, there'll be another study with OCT data that can expand upon this. So just have to stay tuned.
What are some key messages from this paper for our audience? Optometrists that are seeing patients with GA, does this affect how they should refer patients? What are your thoughts?
Yeah, and so what I would mention is, people who have geographic atrophy that have vision that's better than 20/160, that have geographic lesions at or within 1 millimeter of this foveal center, this study says would benefit the most visually. Another step to consider, which we may not have this as we gather data clinically, unless you're taking fundus photographs year after year, where you can put those pictures side by side and kind of eyeball or measure through, as the software allows, whether it's getting closer, but geographic expansion towards the foveal center, in addition to those two data points that I just mentioned, could further add sensitivity to who might benefit most.
Yeah, excellent. I think this is certainly a relevant conversation that patients may bring up during eye exams. And so thank you for sharing such a interesting paper, and I think very pertinent sort of information that we can share with our patients as well. Thanks for joining us, Dr. Bucca.
Yeah, thank you. Appreciate it.